neurological examination of the upper extremities. What are we doing? Why are we doing? What exactly do the findings mean? How do we clinically interpret and correlate these? So this is not a video to demonstrate an examination of the upper extremities. That's on a separate video for which I've posted the link in the description. Rather, this one, similar to my GI video and a few of the others, is actually explaining the findings of the clinical examination and what they actually mean. So, without further ado, I will start in a particular fashion with the examination, the neurological examinations. A lot of clinicians, particularly early on in their clinical years, actually shy away from it. They're not all too confident with it, and they're not sure how to go about it, and it's understandable. So when I conduct my examinations in the neuro side of things, I follow a particular kind of method in my mind, and I follow that sequence. Now, there are no hard and fast rules. You do as you please, the way in which you would like to do it yourself. However, for me, I like to assess the higher centers first, so the cerebellum, and then I move on to the lower motor neurons and assessment of those, followed then by the tracts at the very end. And that's because that enables me not only to understand here in my mind as to what I'm assessing, but also enables that that sequence of events that I'm conducting. So there's a good way in which to ensure that I've conducted the examination in its entirety and as accurately as possible. So, starting off with the examination of the upper extremities, I start with asking the patient to close their eyes, and again, patients to lay on a bed at 45 degrees. I ask the patient to lay with their arms both supinated like so and close their eyes. Here, what I'm looking for is a pronated drift, and that kind of essentially is where the arm will pronate. It's usually unilateral because what we're assessing here really is this is a very strong indicator of a cerebrovascular incident or accident, i.e. a stroke. As well as giving me a good indicator for that, what we're really assessing is elements of the corticospinal tract. Following from there, I then ask the patient to demonstrate this repeated motion. And when we do one side, remember we're assessing the appendicular skeleton, so we have the privilege of assessing both sides and comparing. Here what we'll find is the patient will lose coordination. They'll be very flimsy, they'll be clumsy with it, they might not be able to repeat it, or they'll slow down as they're doing it significantly to the point of termination. Any inability to do this is referred to as dystiokinesia, and that is again indicative of cerebellar dysfunction. Following on from that, I then ask them to do the finger to nose test, and what I will do is I will ask them to do both arms one at a time. I'll usually give 5 points to point at, and what I'll do is I'll move my arm in a kind of an arc around the patient so that they've got these 5 areas where they need to get to. Here, what you'll find in the dysfunctional patient generally is such that they are actually going to pass your finger. It's what I call pass pointing. It's known as dysmetria, and this is because they are unable to judge accurately the distance as well as speed and other vectors associated with, again, indicative of cerebellar dysfunction. The other thing which you might find here is that the patient actually, as they approach your finger, they increase, a tremor appears, and that tremor essentially, they'll get to it, and they're not pass pointing, but there's the tremor that occurs, and this is essentially intention tremor. And intention tremor is better described in my video for cerebellar testing and how we actually assess for that in situations where we're suspecting intention tremor. But this is the suggestion of the same. Again, all of this encapsulates the cerebellum and testing thereof. From here, I'll then go on to the tone, and we're going to assess the tone in the upper extremity. That will be at the wrist, the elbow, and the shoulder. Now, we understand the primary movements with the wrist are your flexion, extension, and then you'll have your ulnar deviation and your radial deviation, followed by your circumduction. And so that's essentially what we'll assess. So we'll do flexion, extension, the ulnar and radial deviation, and then an element of circumduction. Primary movement here, flexion and extension, and then you can do pronation, supination, followed by an element of circumduction like so, And then with the shoulder, we're going to do flexion, extension, abduction, adduction, and then from here in the horizontal plane, you can do circumduction. In the normal patient, this is atonic, it's smooth. However, what we're really looking for are three main things. And what you might find is, and I'll use my elbow to demonstrate, cogwheel rigidity, which essentially you get this jerking motion as you pass through that range of motion, and same again here. So that's your cogwheel rigidity. And the second one that's important here is clasp knife rigidity, lead pipe rigidity I'm going to go with. And lead pipe rigidity is where you get an element of resistance throughout. It's kind of like bending a lead pipe, so that resistance that you'll experience when you're doing that. Both of these indicate dysfunction with the basal ganglia and the substantia nigra. And if you recall, that's all to do with the dopaminergic pathways, therefore indicative of Parkinsonism. Now, Parkinson's disease, because that then becomes a clinical manifestation, and you have to correlate that clinically with other findings to suggest the same. So Parkinsonism is what we're looking at here. And then followed on, the last thing you might look for is clasp knife rigidity. So again, if I go with flexion here, what you'll find is you'll get initial resistance, and then it'll give, and it'll be a normal motion after that. So the initial kind of is resistive, and that's clasp knife rigidity, indicative of an upper motor neuron lesion. From here, then I'll go into muscle power testing, and again, I'm not going to demonstrate all the myotomes that we're going to assess, again demonstrated on the other video, but polite reminder, we're going to measure the muscle power on both sides, again ensure it's equal, and we're going to score this out of 5 using the MRC scale for muscle power testing. Swiftly moving on to the deep tendon reflexes of the upper extremity. Most textbooks or otherwise will give you 3 tests, 3 areas. That's your biceps, your brachioradialis, and your triceps. So C5, C6, C7 respectively. But there is also a 4th one in the upper extremities, and that's essentially with the finger flexion, and that's your C8T1 nerve. And again, I'm not sure if I can't recall if I did demonstrate that on that video. But your deep tendon reflexes, again, polite reminder, we are assessing the integrity of the reflex arc. This is a local arc assessment, as well as an element of the inhibitor neuron and all that side of things. But measures 2 out of 4 is normal, because the scale is up to 4, 0 being absent, 1 being hyporeflexic, 2 is normal, 3 is hyperreflexic, and 4 is clonus. And a clonus indicates an upper motor neuron lesion again. You'll appreciate also hyporeflexia, hypothyroidism, hyperreflexia, hyperthyroidism, but hyperreflexia may be relatively common. You might get brisk reflexes in patients who are avid gym goers, because the muscle is better toned, and therefore the tendon is under that bit better tension. Remember, again, I've done a separate video on DTRs in explaining all of that, and when we're doing a deep tendon reflex, we must ensure that the tendon is under tension to elicit the reflex accurately. The other thing to bear in mind is we need to note, as well as the grading for it, we need to note whether or not they are all present and equal bilaterally, and also whether or not reinforcement was used. And in the upper extremity, we clenched the jaw, so this was with reinforcement or without reinforcement. When we were assessing the lower extremities, we allow the patient to potentially do this, and so as to distract them, and that again enables a more accurate reading. Once we've done the deep tendon reflexes, I then move on. So that's all kind of the motor component side of things done, and so your myotomes and that side, and then I'll move on to the sensory aspect of things. And here I'm going to start with dermatomal assessment. Start with the C5 all the way down to T1. Again, remember C5, C6, C7, C8 and T1. Please remember these must be assessed on the palmar aspect, because the dermatomes are slightly different on the posterior aspect of the dorsal aspect of the wrist. A number of times we see this done, it's diabolical. Remember also, this is Reginald's patch, C5 axillary nerve innervating the lateral deltoid region. C3, 4 is actually around the upper traps. And patients may present with a burning sensation around the upper traps, or a cape-like distribution where the superheroes wear their cape. Those situations, multiple sclerosis, for example, or cervical myelopathy, there's something known as the Lermit's sign, or also known as Barber chair sign, and that's what these 2 things indicate. But in such situations, they will get symptoms of kind of a shock-like sensation down both upper and lower extremities, and that's responsible due to all your tracts, your gracilis tract and your cuneatus tract. So when we appreciate the somatotropic organization of the spinal cord, we'll appreciate why we get that situation, cervical myelopathy or MS, in the whole upper and lower extremities. But we'll cover that another time. Moving on from, so again, C5-2-1, remember C5-2-1 is your brachial plexus, and that's essentially what we're assessing here, so the dermatomes associated with the brachial plexus. From there then, once I've done the sensory testing there, I'm going to move on to the actual tract. So I start with the spinothalamic tract. Spinothalamic tract, the modalities, there are a number, but the main ones are your temperature, your light touch, and your sharp and dull. So they're the ones that we're going to assess for the most part. Most examinations don't really assess the difference between hot and cold, but you can do. Again, we'll go over the dermatomal patterns that we've just identified. And what we're going to do is your cotton wool and then your medipin, followed then by, like I say, a cold object, generally, whether it's a warm object comparatively. This assesses integrity of the spinothalamic tract. Following on from that, I will then finish off by assessing the dorsal column medial lemniscus, or the dorsal column tracts. And here we will assess vibration first using your tuning fork. And remember, it's the lower number, the frequency, so your 128 hertz. So if you get a number of tuning forks, remember, and the body, the way to remember this is when we're doing your Weber's and Ringi's tests, we'll use the 512 hertz frequency, whereas here we'll use either the 256 or the 128. So again, use it on the distalmost joint, and you'll ask the patient to report whether or not they can feel that vibration, follow then on to the proprioception, and both of these modalities go with the dorsal column medial lemniscus. And there you are. So these are the findings and the clinical examinations in that particular order for me, because it's swift, it makes sense in terms of what I'm assessing, and and it enables me to be thorough, accurate, and ensures I don't miss anything. I will do a similar video on lower extremity for the same kind of thing, and how I conduct it in a similar fashion, and what the findings might mean. Thank you for watching.